right. Thanks everybody for joining us tonight. It's exciting to have this panel together today. I'm really excited about this topic. I know this is something that a lot of families who have kids with DEEs are thinking about, dealing with, struggling with. And I was really thrilled when Ashley from Koolen-De Vries brought this issue to us and said, hey, let's do this together, because we know this is something that impacts a lot of our kiddos. So for those of you who don't know me, I'm Gabi. I am co-founder of DEE-P Connections, and just really excited to be with you all tonight. I have a kiddo who is 10 with SCN8A, DEE, and this is a big old issue for us. So I'm sure I will learn a few things along with you tonight. A quick reminder that anybody who's attending the webinar is off camera and you're muted automatically, but I really encourage you to use the chat function throughout if there's something that resonates with you, if you hear something and you think, oh, I want to hear more about that. If you have a question, you can use the Q&A or the chat. We'll be monitoring both. Unless it's kind of a clarifying question about what we're talking about at that moment, we'll probably save the questions for the end when we're going to open up and do some Q&A. I want to remind people that, we can't really give any medical advice here because, well, I'm not a doctor, but Russ is, and, he can't really give medical advice to somebody who he's not treating. So we absolutely encourage you to put questions there, but try to keep them a bit more general about like, if you see this, then this, not like my kid this. So just a little bit of guidance there on that. Otherwise, I'm really excited to be doing this with our friends at Koolen-De Vries Syndrome Foundation, because, I think that we all probably have seen something that comes up in this space, many of us, everybody who's joining, obviously, but, within our communities. So just to kick things off, I'm just going to introduce you to Casey Fisher. She is a KDVS Foundation board member and mom to Cool Kid Hudson. They live in the Nashville, Tennessee area. And she's going to introduce you to her team here who's joining us today.
Wonderful. Thank you so much for the introduction, and just really appreciate the partnership and the ability to work closely with you for this call this evening. This is obviously a very important topic to many of us. And before we turn it over to our guest, Dr. Zweiner, we wanted to invite another special guest to the call just to share a personal story and just to kind of tell you about her own personal experiences. And that is Barbara Drake. She is mom to 8-year-old Miranda, GI issues and epilepsy, along with an insane amount of other things, started pretty much right after birth. And her daughter Miranda was diagnosed with KDVS when she was about 4 months old. Barbara also serves on the KDVS research committee, helps run the KDVS biorepository, and is an avid rare disease advocate. So thank you so much, Barb, for joining us. And I'm going to turn it over to you just to share a little bit.
Thank you guys so much for having me.
I'm just going to hop off camera so we can, if we want to do that, so we can let Barbara highlight her story here.
Thank you guys so much for having me. It's awesome to be here and to be with our people. And Gabi, it was so nice to finally meet you. Sorry, Miranda, hot mess over here today. Yeah, so they wanted me to just come on and just talk about our experience. Kind of, we got hit right away, kind of with the domino effect all at once. When Miranda was first born, the first week of life, she got an NG tube because she wasn't strong enough to be able to suck her bottle, to do anything. So they actually ended up inserting an NG tube. She was diagnosed with dysphagia. About a week after that, she had her first seizure. And then along with that came bowel issues, and she had extremely low tone. And so we went through all the bowel issues that come with everything that I'm sure a lot of you can identify with Miralax, lactulose, suppositories, the dreaded bowel cleanouts, Senna. So we had all of those issues along there. About 6 months old, she had heart surgery at 2 months old. About 6 months old, she needed a permanent G tube because we saw this was going to be a more long-term situation. It was a really scary decision, which I'm sure a lot of people can identify with. but it was actually like the best decision we've ever made. Now I serve on a board at the hospital where families are trying to decide if they want a G-tube or not. So they call me, I talk to them, and kind of just help them make the best decision for their family and their child. But with us getting our G-tube, it turned out to be the most amazing thing ever, because with all the medications she was on around the clock medications every 2 hours. So not having to wake her up and make sure she gets it orally and make sure she wasn't aspirating things into her lungs. So yeah, her G-tube turned out to be the most amazing thing ever. We can keep her hydrated. It kept us out of the hospital I don't even know how many times. Yeah, but we started to get real intrigued with the whole gut health microbiome situation when she started on formula, and she was really sick and vomiting all the time, and her seizures were really bad. And then we started kind of looking at different formulas and different real foods and probiotics and all those different types of things. So when they asked me to speak on this, I was like, that's so interesting, because we were really interested in to start with all of this and everything going on with seizures and epilepsy and G-tubes and all of that stuff. So we were just excited that, sorry, we're fighting respiratory. So yeah, it was really interesting. We were just really excited to come on and kind of share our experiences and kind of have it all. Sorry. We kind of have it all. So yeah, we are excited to answer any questions anybody might have, and we can't wait to listen to Russ's presentation, and we're just so excited to be here.
Thank you for sharing, Barbara. It's so great to see your little one too. She's so cute. I'm sorry she's sick, but she's still precious. So glad she's getting to make an appearance. Thank you for sharing. I know there's a lot of families on the call that will certainly, resonate with them. And again, just really grateful that you are sharing your story with us. So now we will turn our attention to the presentation for tonight. We're really excited to have Dr. Russell Zweiner with us, who is a gastroenterology, hepatology, and nutrition specialist at Children's Hospital of New Orleans. Dr. Zweiner serves as the hospital's interim service line chief of pediatric GI, director of endoscopy, and director of pediatric advanced and therapeutic endoscopy. He completed his general pediatrics residency at Oklahoma University Health Science Center, and then a pediatric gastroenterology fellowship at LSU Health New Orleans at Children's Hospital. He trained further for an additional year in San Antonio to complete a pediatric advanced and therapeutic endoscopy fellowship at Baylor College of Medicine. Dr. Zweiner is board certified in both general pediatrics and pediatric gastroenterology. Although Dr. Zweiner treats all pediatric gastrointestinal conditions, he specializes in caring for children with pancreatic biliary, I should have practiced that more before, disorders including acute and chronic pancreatitis, gallbladder, and bile duct disorders. Dr. Zweiner performs highly specialized procedures, including endoscopic retrograde cholangiopancreatography, or ERCP, and endoscopic ultrasound, or EUS. He is one of the very few pediatric trained physicians performing these procedures on children in the country. Dr. Zweiner is married to his wife, Jamie, who is a New Orleans native and is a father to 3 young daughters, one of which has special needs. Dr. Zweiner has a special place in his heart in caring for children with special needs, and I know that you're just going to love his presentation. So thank you so much, Dr. Zweiner. We really appreciate you joining us and look forward to hearing more from you.
All right, thank you. Is my I don't know if my Gabi, I don't think my camera is on.
Yeah, let's see what's going on there. I don't even see you as for some reason, I'm not even seeing you.
Start the video, it doesn't allow me.
Okay, let me, sorry about that. I think I have to, let's see. Zoom has made some changes recently and it's driving me a little bananas. Okay,
there we
does that do it?
Yay.
Okay.
Now I need to share my screen again, I believe, right? Okay,
Yeah.
Here we go. Yeah. Okay, everyone can see that. Yeah, are we good?
Yes, you're good.
All right, awesome. Very good job, Casey, on those names of those procedures. We should have practiced that. No, thank you very much to Ashley Point, president of the KDVS Foundation, and then Casey Fisher, also, of course, as Gabi said, the board of directors, they're probably best known for being mother to KDVS children. And then also thank you to Gabi for putting this together. Yes, a lot of technical names in my introduction there, but this is going to be a gastrointestinal special needs perspective. So I get a little bit of a different perspective being a physician and then also a father to a child with special needs. So this is Molly. She's 7. She is our cool kid. I know many on here may know her, but children with developmental disability commonly receive services from this complex, network of medical, community, at-home care providers. So each of you on this webinar, each with written or unwritten ideas regarding the purpose and goals of treatment. Parents of children with complex medical needs become adept at navigating these numerous systems of care. There was a quote I once heard in medical school as a physician: every time you see a disease that's fascinating, is always remember that there's a mother or a father somewhere that may be crying. The truth of these words has remained with me, guiding the care of my patients and offering me solace as a parent and greater compassion as a physician, as I think these words embody the humanity, the attitude of humility that healthcare providers must adopt to truly form a healing partnership with families. So I get to see both sides. I think it's from that human aspect, from the perspective of a physician and parent child with this medical complexity that a lot of us deal with, that I can contribute on the family viewpoint and experience of treatment of children with medical complexity. So I'll be blunt with you. Prior to Molly being born, I had a tendency to read these parents as demanding, wanting to dictate the medical care for their children, which frustrated, and I hate saying it, but even annoyed me. So I think now I acknowledge that I did not understand their perspectives, and I was unable to empathize with these parents until I had a child with a rare and medically complex disorder. It was only then I was able to relate and understand the necessity of their proactive, highly involved approaches to obtaining healthcare for their children. I realized these parents were appropriately invested in seeking care for their children, whom they had created, and for whom they were fully responsible for in all aspects of their health and well-being. I recognized that they were motivated by the love of their children to fight and provide the best possible opportunities and outcomes. So I know a lot of you guys can resonate on this. So what we're going to talk about, some of the objectives. So introduction to GI. So just what is GI? What is a pediatric gastroenterologist? Common problems. And then talk about some nutrition, talk about G-tube, J-tube care as well, which I know a lot of you guys can resonate with as well. I'm hopeful that by the end of this, we'll discuss the most common gastroenterology problems that one is likely to encounter when working with children and adolescents with developmental delay and special needs, and how to manage children with GI problems within a medical home, information about when it would be most helpful to refer to a pediatric gastroenterologist, or other specialists working within pediatric GI, such as dietitians and pediatric health psychologists. So interest in the connection between gastroenterology and children with special needs is not new at all, as it has been very well established that gastrointestinal disorders are common in children with neurological disorders. This is one fact that reports of prevalence of GI symptoms in children with ASD is autism spectrum disorder vary from 9 to 91%. So there is a wide range of symptoms. The most common GI symptoms reported for children specifically with autism, I'll say this, but neurodevelopmental disorders are reflux, gastritis, abdominal pain, distension, food intolerance, food selectivity, constipation, and diarrhea. There's food sensitivities, right? So another possible reason for GI dysfunction in children with special needs are food sensitivities. These food sensitivities can damage different tissues, and such as Food sensitivities are thought to stem from an inability to digest efficiently, thus leading to inflammation and gut injury. Gluten and dairy are proposed to be the most common food sensitivities in children. Food sensitivity is suggested to have negative consequences in children with these neurodevelopmental disorders, and is associated with irritability, as we can all relate to food refusal, sleep disturbances, constipation, and diarrhea in children. Just going to briefly look on the chat here because there's something. I'll tell you what, I'll look at these at the end unless something more bigger comes up. We'll do that. So pediatric gastroenterology, right? The study of practice of treating disorders of the GI system within pediatric population. We specialize in caring for conditions that affect any part of the GI tract, also the liver, the pancreas, and then also nutrition. So again, like I said, common presenting symptoms for pediatric GI, like I said, the abdominal pain, got constipation, diarrhea, with or without bleeding, maybe weight loss, maybe weight gain. Children and adolescents with developmental delays have a higher incidence. This is very, very well documented. And occurrence of gastrointestinal disorders and functional gastrointestinal disorders. We'll talk about what that is. So more common than typically developing peers. So universal monitoring, so gastrointestinal problems are common in children and with developmental delay in general. These conditions can range from a very common disorders like constipation, diarrhea, like we discussed, to much less common conditions. Again, gastritis, maybe esophagitis, so that's inflammation of the esophagus. Maybe there may be something related to allergies or small intestinal bacterial overgrowth. These typical presentations of GI conditions in children with these neurodevelopmental disorders vary from children to children. They may vary and range from asymptomatic to abnormal posturing, right? They can't tell us what they're thinking, what they're feeling. They may have self-injurious behavior. That may be an indication, right? They may be hitting themselves or hitting their abdomen is very, very common. Developmental behavioral regression, these sleep disturbances, like I said. So it's important to continue to monitor and screen for certain disorders, particularly those that we'll cover in the next few slides, as children with these neurodevelopmental disorders likely present with atypical signs and symptoms. So very important to identify this early. So a little bit of overview. So pediatric GI conditions are best understood in two categories, organic and functional. And I usually describe this when I talk to my patients. Organic is, for example, if I took a camera and I look inside your child's stomach and I see a big ulcer, that is disease in general. We'll use disease. Let's treat you, let's treat you better, right? Organic diseases are any medical disease process by which there is physical disease or abnormal function of the tissues of the body. These contrast to functional conditions, which there is no physical damage or inflammation, but there is altered sensory processing, such as nerve overactivity or maladaptive socio-emotional response to this pain. So despite the lack of physical findings of disease, functional conditions are real. They're valid reasons for pain and symptoms of gastrointestinal disorders, and we'll talk about those in detail. Many children who initially present with abdominal pain are eventually diagnosed with functional pain when no organic source is found. And there's multiple different reasons for that. Some of the reasons are they've had a very big workup, or and that is one big thing, that these disorders that we'll talk about that are functional in nature aren't like I said, they're real, and we'll talk about those. So I'll talk about some organic things first, right? So failure to thrive. Sorry, I lost it for a second. There we go. So identifying when growth, right, falls outside the realm of normal is important. Failure to thrive is a condition of inadequate growth or inability to maintain consistent growth over time. It usually falls into four categories. They're either, so inadequate nutrient intake, they're either not getting enough, inadequate appetite or inability to eat large amounts, again, not getting enough, inadequate nutrient absorption, right, or increased losses, right? They may be vomiting a lot, or they may be having lots of diarrhea that they're not absorbing these nutrients, or increased nutrient requirements, or ineffective metabolic utilization, right? So increased requirements, maybe they have a heart condition that they're burning more calories, that type of thing. So there are special growth charts that have been developed over time for, say, Down syndrome, Williams syndrome, Turner syndrome, prematurity. So poor weight gain that results in severe malnutrition can cause this persistent short stature or not growing, secondary to potentially an immune deficiency and permanent damage actually to the brain and the central nervous system. So medical, nutritional, developmental, behavioral, and psychosocial factors may all contribute. Assessment of the growth trajectory of the growth chart and proportionality may provide clues to the etiology of why a child may not be growing. So nutrition, right? It's complex, right? So if your GI doctor is 1A, your dietitian is 1B. That's what I always say. So the dietitian, right? These experts, know a lot of you guys can relate to talking to your dietitian. You're probably talking to your dietitian a lot more than you're talking to your doctor. But experts who translate this nutritional science into evidence-based recommendations designed to assist children and adolescents to live healthier lives. The relationship that people have with food is complex. And complexity often begins in early childhood. So for some, this complexity even begins in infancy when there may be metabolic syndromes or genetic disorders, right? That's what we're talking about, genetic disorders requiring special diets that are identified. For others, there may be neurological or physical disorders that impair this feeding. They may require a enteral feeding, which is by means of, say, using a G tube or a GJ tube or an NJ tube, a nasogastric tube. So working collaboratively with a registered dietitian or a nutritionist is important in supporting the overall health of the child with these challenges. It is so very important. Adequate nutrition during the first 2 years of life is critical for neurodevelopment, since these deficiencies during this period increase the risk of lifelong challenges such as learning disabilities and poor growth. So adequate nutrition is typically achieved by consuming a varied diet of fruits, vegetables, whole grains, lean proteins, low fat dairy, and healthy fats. Barb was talking about, these real foods, right? The G tube or enteral feeding via that. It's a big hot topic of these real foods nowadays. So feeding challenges in infancy place children at a increased risk for later feeding issues. A fifth of all NICU graduates, so like babies coming from the ICU, experience feeding difficulties. So it's a lot. So feeding disorders, mealtime challenges, and the risk of overweight and obesity are common concerns for children with developmental disabilities. Feeding problems, as we know, are more common in children with a developmental disability. By toddler and preschool years, I'd say mealtime challenges are common. That's where you get the parental concern for many families, but parents of children with these neurodevelopmental disorders who do not consume well-rounded meals. Mealtimes are reported to be stressful, chaotic, lack of positive interactions, and guilt-laden, right? We all can relate to this. So nutritional issues can be very, very complex and are often multifactorial. So many different reasons why. If not addressed early, it can impact the child's health, development, and general well-being. So this needs to be get on ASAP. So as a group, children with intellectual disability are at increased risk for gastrointestinal issues, with underweight being the most common, which is why these NG tubes, G tubes, and GJ tubes are very, very important. So this is, and I won't read all this, but this is what a dietitian is going to give someone. This is what ours gives our patients. But it's important to write everything down. I think that number one is most important. Write every single thing down. Every single thing down. If they sneak some gum, you write it down. And you're recording this over 2 weekdays and 1 weekend day. You want to describe how the food is being prepared and baked and that sort of thing. So this is so very helpful for our dietitians that will be able to come up with a good plan. So this may be something that a lot of us think about, right? So we change the diet, right? So fad diets galore, right? Do they really work, right? There's the red dye diet. So red dye, it's based on the premise, or I should say lack thereof, red dye, but it's based on the premise of that artificial food dyes, especially red 40, are linked to behavioral issues in children, especially those with autism spectrum disorder, attention deficit disorder. So food dye is added to the food to increase this visual appeal for children. So it's prevalent in foods aimed at childhood consumption. These food dyes are prevalent in most processed and some unprocessed food, which can make it burdensome for the families to avoid, especially when dining outside of the home, that type of thing. Before trying such an elimination diet, families need to consider their specific child's eating habits and if their child would be able to keep up with an adequate level of food. It can be very difficult. Gluten-free diet without evidence of celiac disease or allergies. This is big, right? So we diagnose, I won't talk too much about this, but we diagnose celiac disease, which is basically a gluten sensitivity, but there's a non-celiac gluten sensitivity, and a lot of kiddos can be sensitive to gluten. Ketogenic diet, I know a lot of you guys, I'm not going to talk too much on it. Not my obviously I'm a pediatric gastroenterologist, and this is what the neurologist would run, but it's extremely low in carbohydrates, moderate in protein, and high in fat, and is based on research evaluating the effectiveness in controlling drug-resistant seizures. I know a lot of you guys can relate to that. Its aim is behavioral symptom reduction through reducing these metabolic disturbances. So that's about all I'll say on that. So probiotics, right? So the use of probiotics is based on the theory that individuals with neurodevelopmental disorders have altered microbiota, right? We have millions of microbiota, 15,000 bacteria that are in our gut, for which daily probiotic use will improve, in turn improving gastroenterology and behavioral symptoms. So given the limited harm in probiotic use, several medical providers do recommend them, their use, despite unclear evidence or etiology of benefits found. So probiotics are live microorganisms which are administered in adequate amount to provide a health benefit in addition to their nutritional value. So probiotics, and I'll mention prebiotics, are considered as food supplements. So they're not regulated by the FDA, they're a medical food. So I think in the next couple of years, it's a very hot topic in research right now. We're going to see a lot more clinical indications for them, which I think is a really good thing. All right, G tubes and J tubes. I don't know how I would explain all this and put it on one slide, but here we go. So reasons for needing a feeding tube, right? Medical necessity. So where your child cannot meet the caloric needs due to a medical condition, whether that be heart, neurological, muscular, digestive disorder. Do they have failure to thrive, right? Often because of these food aversions. Meal times can be very, very difficult. Do they have trouble learning to suck, swallow, and breathe, right? This is a very big decision. Understand that it doesn't always mean it's a forever situation, though, and that's my main goal when I talk to families. So most common signs your child may benefit from a feeding tube. So number one, if your physician brings it up, I'd probably listen to them. And if you're starting to noticing developmental delays, are they malnourished? Right. So, we all bring up our growth charts and show, are they on the curve? Are they off the curve? Have you tried other options, right? Without success, and or if you're feeling just helpless, really. So, they require a lot of upkeep. They do not come without problems. There can be granulation tissue. This is tissue that can grow around the tube. There can be infection. There can be leaking around the tube. The tube can be too big. The tube can be too small. There can be blockage of the tube. The tube can migrate. So they're not without problems. The majority of the times they do well, but they're not without problems. But they can be, as Barb said at the very beginning, it can be one of the most life altering changes that you can do for your child, especially if they need the nutrition. So going into some more organic disorders, right? Vomiting. Now, vomiting can be organic or functional, and we'll talk about that a little bit, but this is a common complaint in pediatrics. It's non-specific symptom, which can represent a variety of issues, can be from different organ systems. It's not always the GI tract, as much as everyone thinks it is, but they can come from your kidneys, it can come from your brain, your central nervous system. So it's important to well characterize these vomiting episodes for your physician or care provider who's going to be asking you. So what is the duration, right? The frequency, the contents, what is coming up? Is it blood? Is it green? Is it bilious, right? Is it related to any type of food or a certain time of day? That type of thing. So concerning, what I would say is the most common concerning features is that if it's bloody, if it's coffee ground in nature, that's indicative of a GI bleed. As well as grass green colored emesis, which could be concerning for bile. This would direct me towards considering an obstruction or something called ileus, where your bowels just kind of go to sleep, or even malrotation, where sometimes your bowels can actually twist as well. I'll mention a little bit. I think I talked about it a little bit, but rumination, which I will discuss, it can easily be confused with vomiting. So vomiting with growth failure or weight loss is highly concerning. So when there's growth failure, children may need to be hospitalized to monitor for something called refeeding syndrome, which when someone hasn't been nutritionally adequate for a while and they start to eat, they can have lots of imbalances that go on. Going on, so gas and bloating, right? Gas, bloating, abdominal pain, very common complaints for all children. But as we know, this can be very challenging for those with developmental delay. Gas is either, I'll tell you, two ways, right? So gas is either swallowed, or it's released from the foods we eat, or created through a breakdown of foods. Air swallowing, or something called aerophagia, is very common in children with developmental delay, and especially in those that hold their mouths open. This air can be expelled, as we know, through burping, but all kids with developmental delays can't do that. Or venting. If there is a G tube, you can vent the G tube and be out that way, get it out that way. Now, there's a surgery that can be done, which I'm sure some of you can relate to. If there is a G tube or a GJ tube, sometimes kids will get something called a Nissen fundoplication, where they actually wrap the stomach and have patients have really bad severe reflux. And essentially what that does is you wrap the esophagus around the stomach around the esophagus, leading to so they don't have this vomiting or reflux coming up. Now you can have a complication from it where you can't release that air if they're swallowing that air, right? It's because it can be a tight wrap. So patients, it makes them more difficult, I guess, to self-regulate, so to say. So food allergy, right? Could this be a food allergy? It's estimated that this can affect 1 to 2% of the general population, more in patients with neurodevelopmental disorders. The most common that we're going to see, and we work hand in hand with our allergy and immunologists, but cow's milk, eggs, peanut, tree nuts, soybean, wheat, fish, shellfish, these are going to be your most common. It's important to note that food allergy is the most common cause of outpatient anaphylaxis, or a severe allergy, right, reaction. So causing either a rash or trouble breathing. So it must be treated with utmost concern. A workup for a food allergy should only be performed when a patient presents with these symptoms. However, a patient with a neurodevelopmental disorder may not be able to communicate, right, with these symptoms, but rather may just strongly avoid particular foods. That could give a physician a clue. Patients with neurodevelopmental disorders may already have a very limited diet, as we know, due to multiple factors, including oral aversion, inability to perform mechanics, consuming certain foods, or specific preference towards select foods. So an additional food exclusion may add unnecessary complexity to a child's daily life. There's increased anxiety regarding fear or allergic reaction, and increased social isolation, right? Due to being excluded from meals shared at social gathering or in the classroom, that may significantly impair their quality of life. There is also a possibility of contributing to delayed growth and vitamin and dietary deficiencies. So, these symptoms can present with skin, GI symptoms, right? Even respiratory. So, and they may include nausea, vomiting, diarrhea, cramping, abdominal pain. So very, very important to look up. So this is something that I know Gabi wanted me to discuss, and it's one of those I know has a lot of traction and talking about the what we call the gut brain axis, or the gut brain interaction. So and a DGBI is a disorder of gut brain interaction, and these terms functional goes hand in hand essentially. So right, the gut and the brain are a part of something called an enteric nervous system. The brain is the central nervous system. So the gut brain axis refers to this bidirectional, right, going back and forth of communications between the central nervous system, or that CNS, or the autonomic nervous system and the gut. This begins all the way back in embryology, when a fetus is being formed. So the very beginning of when that spinal cord and that brain is being formed, these nerves and the gut are being formed literally at the same time. And so that's why one may hear the gut is the second brain, and it really is. And so when you get dysregulation of the system between the brain and the gut, that's when you start to get these disorders of gut-brain interaction. They can be related to any combination of having issues with motility, right? So motility is the way our gut moves or moves things along. Visceral hypersensitivity, right? These sensitive nerves causing pain or causing other issues. There may be altered mucosal or immune function. There may be altered gut microbiota. And then, of course, there's the altered central nervous system processing. So these, like I said at the beginning, these are positive diagnoses rather than a diagnosis of exclusion, right? These often can be diagnosed based on symptoms. And an extensive workup is not usually needed. Now, that usually isn't the case because we want to a lot of times we want to make sure that we're not missing anything. So functional GI disorders, extremely common among patients with GI symptoms. So in pediatric gastroenterology clinic, over half of the patients met criteria. This was in a study actually I did in fellowship. Over half of the patients, and this is every patient, met criteria for one or more functional gastrointestinal disorders. Among children less than 4 years of age, 29% met criteria for what we call functional constipation. 13 had something called infant regurgitation or reflux, and 10% had something called cyclic vomiting syndrome. Treatment of these functional GI disorders works best when practitioners use something called the biopsychosocial model. So you can look at the words in that: bio meaning organic disease, psycho meaning the psychological approach, and social meaning a multimodal family approach to understand and conceptualize these patients' problems. So appropriate treatment of functional GI disorders includes interventions that address all areas across biological, psychological, and social domains that may be impacting a child's health or child's symptoms, and often includes interventions from a multidisciplinary team. Again, these include GI psychologists, dietitians, and others. So here's one. So rumination, like I said, very, very different from vomiting. Our chief complaint that's going to come in is going to say vomiting 100% of the time. It's more that we get the history to determine what rumination actually is. So it's defined as repeated effortless regurgitation of recently ingested food over at least a month that's not caused by a medical condition. It doesn't always have to be after eating. I always say that too as well. They may expel, they may re-chew, they may re-swallow the contents of their rumination, right? So this is not a violent, this is not a forceful, this is effortless. It's differentiated from recurrent vomiting through the apparent effortless and voluntary nature of the behavior. Rumination is not typically associated with pain, nausea, retching. However, some individuals do note symptoms of abdominal pain and nausea prior to these episodes. It's most likely to occur immediately after a meal, like I said, but usually stops once the gastric contents become acidic. So I will say though that rumination additionally can serve as a means of an escape or an avoid of an unpleasant experience. So like if they want to avoid or dislike a food at the end of a meal, maybe receive social interaction, maybe they're trying to get attention during a cleanup from the caregiver. Behavioral, so often a referral to a licensed psychologist, behavioral analyst, mental health provider is warranted. Behavioral strategies have the strongest empirical support for this. They really, really do. So rumination can serve as a self-soothing or self-stimulatory behavior that is essentially automatically reinforcing among individuals with developmental disabilities. So thus, I'd say the enjoyment of the behavior or the pleasant sensory experience occurring with rumination episodes serves as the reinforcer that maintains the behavior over time, really. I'll mention a little bit about Pica. This is an eating disorder or a feeding disorder that's common among individuals with developmental disabilities that can lead to gastrointestinal complications. So basically what this is persistent ingestion of non-nutritive or non-food items over at least 1 month. What do we most commonly see? Maybe plastic, maybe cloth, maybe dirt, paper, paint, rocks, soap, and God forbid, even feces. I've seen that too. So ABA therapy and behavioral interventions are going to be your most widely supported evidence-based treatments for this. So while working towards an effective intervention, efforts should be made really to maintain the individual's safety, most importantly. All right. We got here constipation. Let me just see how we're doing on time. 43. So I probably got about 7 more minutes. So we're just going to run just a little bit over the so we'll have about 10 minutes for questions. So chronic constipation defined as 2 or more of the following symptoms within the past 3 months. Straining during more than 25% of defecations, lumpy or hard stools. I'm sure most of you guys know the Bristol stool scale by now. If you guys have seen a pediatric gastroenterologist, it's the chart that we all bring up to describe what our poop looks like. I would say that you just need 2 or more, but I'll say the majority of patients usually have all 7, especially if they're coming to us for a second or third opinion. Often chronic constipation begins with a painful bowel movement, okay? The child then develops this subsequent withholding behavior to avoid another negative or painful experience when holding. So over time, the child may develop this pattern of fecal retention, which further perpetuates the cycle of large, painful, and difficult bowel movements due to constipation. Encoparesis is a psychological or psychiatric diagnosis, which describes actually a pattern of bowel movements. This is accidents, right? My child's having accidents. Describes a pattern of bowel movements and passage of feces that occur in inappropriate places, including clothing, and then or on the floor. Functional constipation occurs more frequently in children with developmental delay, and then typically developing children. In children with neurodevelopmental disorders, constipation is likely to present as avoidance of sitting on the toilet or refusal to engage in toilet training. Or appearance of pain or straining behavior when trying to have a bowel movement. Many children will develop this overflow incontinence, a condition in which there's a large mass right in the stool of the rectum, and children can have leakage of the stool in the underclothes or the underwear during day or night. Encoparesis, I will say, can only be diagnosed in a child that's at least 4 years of age or equivalent cognitively, right? So you can't diagnose this if they don't have that, if they have the cognitive ability of an 18-month-old. How do we treat it, right? I always say, right, so a lot of, I get a lot of second and third opinions as well. And I know I do a lot of advanced procedures, but I still see a lot of constipation and reflux. And the treatment of it, constipation comes from a biopsychosocial model like we discussed. When both constipation and encoparesis are present, it's important to treat and manage the constipation first, but before addressing toilet concerns, right? So treatment is going to include, we all know these, right? So Miralax, lactulose, or something of a stimulant laxative like Senna or Dulcolax, depending on the severity of the constipation. I always tell my families that I don't do a lot of things different. I give a lot of education of why this is happening. I do a lot of the same medicines that the pediatrician made, but if I can explain to them why this is happening and what we can do to get them better, then that's, I consider that a successful visit. So often pediatric GI clinics and pediatric gastroenterologists and psychologists will work together to develop these treatment plans, and that's really what the best thing that's going to be for chronic constipation. So as Barb had mentioned earlier, we sometimes have to use hospital-based cleanouts for cases of impaction, very large stool within the rectum. So it's very helpful to include a stool diary. I will say that can be very helpful to assess the frequency and consistency of the bowel movements in the past 2 to 3 weeks before seeing a provider, as well as a list of medications that have been trialed from that standpoint. So functional abdominal pain. I will say, so organic causes of symptoms should be ruled out with a consideration for reflux, right? Ulcers, inflammatory bowel disease, appendicitis, gallbladder disease, maybe oncological conditions. So we have to be careful and mindful, select these diagnostic tools and procedures and tests to explore or possible organic causes, because there's a lot of unnecessary tests and procedures that can exacerbate these functional symptoms and increase family anxiety that a serious or life-threatening disease. So this functional abdominal pain is recurrent chronic abdominal pain that's not attributable to any organic disease. These symptoms can range from postprandial fullness, right? So they're getting full after meals. Maybe they're getting full, getting full after meals or feeling full, and are getting full fast, nausea, upper abdominal pain, burning, right? Or it could be associated with defecation. Is there irritable bowel syndrome? There's functional dyspepsia, abdominal migraine, not otherwise specified, or aerophagia. So the diagnosis can be a challenge. So I use this consistent language about child's pain and convey an understanding that the child is experiencing pain. That's my thing. This is real pain. It just comes from a different pathway of pain. They come in and say, oh, my pediatrician thinks I'm crazy. They think it's all in my head. Well, it's not necessarily all in their head. A lot of these kids too may have anxiety, or like I said, our patients with neurodevelopmental disorders, they have these real pain. That's the brain gut. That's where we're getting that from. So there's very unique challenges that may emerge when addressing this abdominal pain for children diagnosed with developmental delay. So depending on the child's level of functioning, the child may have difficulty communicating to us, describing the symptoms to the caregivers and the physicians from that standpoint as well. So families benefit from having a clear conceptualization of the pain experience, I think, and this allows for increased engagement and commitment to the treatment of the pain. So finishing up here, so what is on the horizon? There is hope. Ron Kaufman, so his family founded the Autism Treatment Center of America in 1983. So, and I'll just flat out read this, but his message highlights the importance of hope, right? So that's what a lot of us are looking for, right? We just want hope. We're trying to do the best for our child. For patients and families and clinicians. He writes that although there are no guarantees, families should never have to accept a message of discouragement as a certain reality for their children. So instead, he gives this message that hope can only lead to beneficial rather than negative results. He points out that the value of families being open to possibilities in their child's future as a necessity for improved outcomes, even when others have diminished expectations, and not to assume these limitations must be a reality. So I think with some diagnoses, a general prognosis is known. We don't know that with both of our disorders or kids with or patients with DEEs or KDVS. So however, with the spectrum of developmental delay and intellectual disability, commonly seen in children with medical complexity, it's not always, how do I say this, possible to predict that a child will be able to accomplish, and what this and what symptoms may be lifelong limitations. So I think it's important for us, me as a clinician, to meet and others meet the patient and the family where they're addressing each symptom to best of their ability, and providing the necessary education, instructions, and resources and referrals to address these symptoms. So as the patient becomes an adolescent and gets closer to adulthood, it's important to provide information for transitioning to adulthood. So I think for now, this is my family. We'll continue to cheer on Molly and support her in her ever-changing needs, just as you all will continue to support your children. She will always know that both Jamie and I are committed to not just making her world better, but doing it as a team. So I think we can all relate to this. And me and my wife, we actually have given a talk of what it's like raising a child with special needs to residents and fellows and PA students. We always give this quote, as Amy Wright, a mother of a child with Down syndrome, stated when she won the CNN Woman of the Year. She said, I would not change you for the world, but I will change the world for you. So I'll end on that. I know it was very brief. We could talk about this for, I feel like, a week, but that is it. I'll do a little plug here, but we do a yearly, COVID put us out for 4 years, but we do a yearly a thing for KDVS, and we're able to support the KDVS Foundation called Brew for Molly Moo. So we're happy to do that on March 18th as well. So with that, I will end the slideshow here. Let's see.
Dr. Zweiner, it looks like there's some questions in the chat.
Yeah.
I don't know if you can see those,
Yep.
if you're able to answer the ones you're comfortable with.
Yeah, absolutely. Let's see here. All right. Okay. We go to the top. Okay. Let's see. Absorb the question. Okay. I'll read it and then go. So can you explain the difference between gluten intolerance and gluten sensitivity and the effects of each? So yeah, so gluten disease, celiac disease is a gluten, right? So in celiac disease, we actually have in our small intestine, we have villi that help, finger-like projections that help absorb all of our nutrients and everything that we need. When in celiac disease, what happens is, because of gluten, and what happens is, in that essentially, instead of losing this absorptive material, what happens is now they're flat, and so you lose this absorptive area. And so you can imagine you can absorb a lot more going through all these finger-like projections, and now they're just going straight through. So that is going to be your true celiac disease, your gluten allergy, so to say, sensitivity. Now, your non-celiac gluten sensitivity is one of those. I describe that as a trial, just a trial basically, and just with my patients, and just say, look, I see this. It can happen. Why not just go on a trial? Now it can be difficult, right? A gluten-free diet is difficult. It's usually not just a diet for the child or the patient, whoever's being treated. It's usually for the whole family, right? You have to go to the grocery store. So that's really what that is. Celiac disease is going to be your true gluten sensitivity. Now, with celiac disease, that's all going to grow back. Your villi are going to grow back, and you're going to be able to absorb when you remove gluten. So that's that. Let's see. How do you treat? Yeah. So how do you treat rumination in children with severe developmental delays? It's tough. Very, very difficult. Rumination, a lot of times we'll try to do something called diaphragmatic breathing. How am I going to tell a child that isn't going to understand how to use your diaphragm to breathe? So I think really that's going to be the most important thing is going to be just protecting the child, right? So the fear is that they're going to aspirate, potentially on that ruminated material. So if this, becomes that much of an issue. Now, sometimes we can use different. We have these are all off-label, so don't take this for or any medical advice. But sometimes a medicine called cyproheptadine or periactin, a medicine called amitriptyline, a medicine called gabapentin. These are all medicines that can be used to help decrease that signal down between the brain and the gut. So I use those for a lot of my functional gastrointestinal disorders, but it's tough. And so, yeah, good question. Let's see, GI function and abdominal seizures. I'm not quite sure what is meant by abdominal seizures as a cause for chronic intestinal pseudo-obstruction and gastroparesis or severe. I don't really know what it means, but yes. So we don't really know what causes chronic intestinal pseudo-obstruction. Essentially what that means is basically a bowel obstruction in the absence of any mechanical obstruction, right? So think about something, if I were to hold off a gut and just close it, that's an obstruction. What a chronic, this panelist or what this person had said was as a cause for chronic intestinal pseudo-obstruction, what that means is there is nothing. The gut is completely normal and it's fine. A lot of times there will be some dilation. But the motility or the way things move can be very, very difficult. And I think that all goes back to that brain-gut interaction. I didn't really talk on any medications like erythromycin that can help with improving gut motility. But I think that's definitely a talk for another time as well. Have you seen a seizure disorder cause vomiting? Can't really speak on that. I mean, I can speak. I haven't had a patient, I guess, so to say that have you seen a seizure disorder cause vomiting? Yeah. I mean, I don't think. I mean, I guess I can speak on that. I would be hesitant to say that a seizure disorder specifically is causing the vomiting. I think it all goes back to the brain gut access. They go on to say the vomiting has stopped over the last couple of months with different types of seizures. Okay, so you're getting a little, there's a culprit also has severe motility issues. Yeah, I may not be able to speak on that one, but I can, what we'll do too is a lot of these questions too, I can, I'll do a little bit more digging and can get some, maybe some better than just on the spot answers for you guys, and maybe we can send that or post it at some point. With chronic constipation and daily stool softener going regularly 2 to 3 times a day, but that is obviously not enough. Are weekly enemas warranted? I've always been a fan. So enemas of trying to avoid going down below. I guess my key is, now a lot of times it's not, we can't avoid it, right? So if we have an impaction, if there's something stuck there, you can give all the Miralax and stool softener you want, and it's not going to be removed. You have to disimpact them, right? That can be done by a suppository, an enema, and sometimes we have to do this under anesthesia and literally remove it before you can start that. No, I have a lot of patients that are on weekly enemas. A lot of them have neurodevelopmental disorders, and that's what keeps them. And the only reason I'll tell you is why I try my best to avoid, right? So a lot of these patients have already gone through trauma, right? They have they've essentially tried to, they've been terrified. I have patients, families that come in and be like, I literally cannot believe what just came out of my child. So, imagine, the fear and the pain of wanting to go and trying to go. This is with typical kids. And so, we can also see this with, patients with neurodevelopmental disorders as well. So I don't think it's dangerous. I try my best to avoid them if I can. What I always say with Miralax and lactulose, there's no magic dose, right? So I know a lot of we're thinking about the magic or what dose do I give? How much do I give? The magic dose is what makes your child, is what I usually say, what makes your child poop, soft. And I always say it could be 3 people lined up. One may need a teaspoon, one may need a 1 capful, one may need 3 capfuls a day, but that's what keeps their stool soft. Because you can imagine what happens is the colon gets very distended. When your colon gets distended, that's our signal that we need that goes to our brain that says, oh, I've got to go. And that's happened in babies and toddlers and school age kids as well. So if your colon is already distended, you're not going to get that signal to poop. And that's when you're going to start seeing those accidents. and you're going to see the leakage around. So that's why I think just being persistent with that is just so very important. Will there be a downloaded link? Yes, there will. I think Gabi can contact or can answer that. Have you heard of MACE? So we now have to use one, but now an ileostomy. Yeah. So ACE is essentially what this is. MACE or ACE is essentially. I think of a G tube that's in your right lower quadrant, right? And so what this does is for patients that do have severe motility issues and just can't, giving all the Miralax in the world, lactulose, stool softeners, Senna, everything. And essentially what it is a retrograde enema. So essentially what you're doing, I think they're great. I think they're good for a select population. If these issues are going on or just severely chronic, I would highly consider it, because it makes one's life extremely helpful and easier, because all you do is you put it retrograde in and it clears the colon out just like that, without having it to go through the entire system. Literally goes right into the colon. So good question. How do you diagnose cyclic vomiting syndrome? Good question. So that looks like the last one. And I will tell it to Gabi, if there's any other questions that come in, I'm more than happy to answer them, like I said, offline. So cyclic vomiting syndrome is diagnosed, essentially you need about 3 months of symptoms. And essentially what it is this violent, forceful, repeated episodes of nausea and vomiting that are essentially separated by periods of back to normal baseline health. So for example, my child may come in and say, my child vomits once a week. But when they do it, it's like for an hour, it's heaving, it's going. And then in between, they're completely fine, like nothing even happened at all. And again, it's separated by periods of back to normal baseline health that can't be explained by anything else, right? So that's why I'm asking those red flag signs. Do they have weight loss? Is there blood involved? Do they have abdominal pain associated with it? In the absence of red flag signs, the chances of organic disease are very low, actually, believe it or not, are very low. And so cyclic vomiting syndrome is a disorder of brain-gut interaction. And so a lot of times, if you tell me the symptoms, we can make that diagnosis and can treat. And we do have medications to treat that as well. Again, cyproheptadine and amitriptyline are both medicines that we use for to help prevent these episodes. Can we please know where to go to ask questions offline? I think Gabi will help with that. I think I hit on everything, maybe.
Yeah, that was a marathon there to get through. Thank you so much, Russ. I think, we hit on a lot tonight, and maybe what we can do for other questions is we can have a Q&A sheet that will, I can share anything else that comes in. People are welcome to write. I'll put the website, the email in here, info@deepconnections.net. Feel free to send your questions there, and anything that didn't get answered online, we can kind of put up a sheet with some answers, and anything else that you're able to dig into more. I know, Russ, there were a few things you wanted to check in on and look into a bit more. So thanks for doing that. This was fantastic. Thank you so much for taking the time, sharing your story, sharing your honesty about how you kind of, before you became a parent to a kid who had these challenges. I think a lot of us butt our heads up against doctors that don't get
Absolutely.
it. So,
Yeah.
I don't know, you're welcome to share insights there of how we get through to doctors too, if there's doctors that don't listen or don't take it seriously. I don't know if you have any insights there.
Yeah, I go back to I don't know how anyone can empathize if they don't have a child with special needs. They just won't, and they just don't get it. And they're not few and far between. I'd say that, but like you just I think if you're blunt and honest up front and just tell the physician what your goals are, at the very beginning, and what and how, how that physician parent relationship can work together. I think just being upfront, that I think that's the most important, is to just, have, want their respect and their honesty, to know that, this, this isn't as simple as just regular belly pain. Things are very different in our children.
Yeah, and I think especially in our kids who really can't communicate, there's no verbal, we really are it's a guessing game, to try to figure things out. If you have
Absolutely.
2 minutes, maybe we can hit, I see a couple more questions came in. Do you know how to treat aerophagia?
Aerophagia, so like trouble, so air swallowing, basically, that functional GI disorder. Typically it's lifestyle changes, depending on what the cause is. So, and this can be very, very difficult, because how are you telling someone with a neurodevelopmental delay to practice breathing exercises, to change the way you swallow, right? To take in the medications, to eat more slowly, right? These are all things that we're going to be swallowing more air. Our neurotypical children, we're saying, things that are going to have more air is going to be your carbonated beverages, the straws, believe it or not, chewing gum. We try to take away all those things. And then there is some research that even undergoing speech therapy as well, to minimize air swallowing. So I would say I utilize that the most if I'm seeing that in my patients with neurodevelopmental developmental delays, is to utilize speech pathology. So whoever had asked that question, if you haven't, reach out to them to see if they have any other options. But it can be difficult. So good question.
Yeah.
Yeah.
And then, is Zofran a long-term solution to vomiting?
No, I mean, Zofran's, great in the short term, as an anti-emetic, it was, used as a anti, for cancer patients, for emesis, but no, it's not long-term, it's short-term, absolutely. It's always good to have some on board, but I think the overall overarching goal is to determine why are we having nausea, why are we having vomiting, is there an organic cause for it, right, or is there not? Again, like I said, these are again off-label, but we do have different medications that we can use that can help with functional nausea, functional vomiting, that are more would be more on the long term. Again, that includes amitriptyline, that includes cyproheptadine, and some other goals. But I think it all goes back to the just figuring out what the overall cause is, and then once you know the cause, then you can narrow down your treatment.
Yeah.
Because they may be vomiting because they're being fed too much through their G tube. A stomach can only hold so much. So there may be, kids that are getting an entire bolus that, that are vomiting, and, pediatrician may throw, Zofran, maybe this helps, maybe it worked, maybe it didn't, when all it really took was to maybe spread out those feeds or do them continuously overnight or over a period of time.
Right.
Yeah.
Yeah. Lots of variables to look at. So, well, thanks again, Russ. This was really informative. A lot of great things. I think we probably could do 3 or 4 more webinars on this to dig into all the different issues. But
I'll be back if there's a GI connection. Just let me know for sure.
okay, I appreciate that. Yeah, no, this is terrific. I'll just also remind people that later this month, we have a webinar on the Inchstone project, which is a really exciting project we have going on to look at how we can really measure progress in kids who have really severe developmental challenges, and who can't talk, who can't walk, who can't, communicate in a lot of traditional ways. So making sure that we can measure their progress so they can be included in clinical trials, so that we can find appropriate treatments for our kids, is going to be critical. So we'd love to have you join us to tell you a little bit more about that. As always, check out deepconnections.net for all of our events. Follow us on Facebook, Instagram, Twitter. We try to be there. And thank you all for joining us tonight, and we'll see you next time. Take care.
Bye.